Welcome to today's webinar, jointly held by LiVDerm and CMHC, The Buzz with Newer Weight Loss Treatments, Implications for Cardiometabolic Health, Facial Aging, and Quality of Life. We are honored to have two esteemed faculty joining us for today's discussion, Dr. Fatima Stanford and Dr. Shasa Hu. Dr. Stanford is an associate professor of medicine and pediatrics at Harvard Medical School. She is an obesity medicine physician scientist and educator, and specializes in the care of adults, adolescents, and children with overweight and obesity. Dr. Hu is an associate professor of the Philip Frost Department of Dermatology and Cutaneous Surgery at the University of Miami Miller School of Medicine. We love questions, so please feel free to submit questions via the Q&A feature in Zoom, and if there is time at the end, we will pose them directly to our faculty for discussion. We will kick off today's webinar with Dr. Stanford on why there is such a buzz about obesity treatments now. Dr. Stanford, welcome.
Thank you so much. It's a delight to be here. And so today we're going to talk about why there's such a buzz about obesity treatments now. I think that we're at a true inflection point as we talk about this disease of obesity, this chronic relapsing multifactorial disease. And a few things I'll say at the outset of my presentation, and that will guide us as we move forward into my slides and then into Dr. Hu's. We want to make sure that we use people first language when talking about patients that have this disease. Please eliminate the word obese as a descriptor. Persons have obesity, but they are not defined by it. So we wanted to eliminate that. Another terminology or term I would like to eliminate as it relates to obesity is morbid. As it relates to obesity, we don't call it morbid cancer. We don't call it morbid COVID-19. We don't call it morbid heart disease, et cetera. Let's stop calling it morbid obesity and refer to it with just the severity of the disease. So it's a delight to be here as we kind of get into understanding what we're seeing about obesity here in the United States and around the world. So we're going to start looking at obesity burden and comorbidities. And I want to start off just by looking at what we see in terms of the current prevalence of overweight before we get into obesity in adults throughout the world. I do want to note that this is taken from the World Obesity Federation and their most recent data pulled just on February the 28th of this year. And I want you to notice that we're looking at a heat map here. So the darker the color, the higher the intensity of the disease. If you're looking at us here in the United States, for example, when we're looking at prevalence of obesity, we're looking at, or overweight, 50 to 70% of the population. We can see this in North America, South America, throughout Europe and Asia, and even in parts of Africa and Australia, pretty high rates of overweight throughout the world. When we get into looking at the prevalence of obesity, now we're talking about the prevalence of obesity by BMI criteria, and I do recognize that BMI by itself is not a great it's a great population-wide measure, but not necessarily at looking at the individual patient. So with my individual patients, I never give them a target BMI, I give them a target health and getting to the happiest, healthiest weight for them. But let's look at the prevalence of obesity in adults, looking at key areas that really stand out where we see high prevalence. Of course, us here in the United States, we can see Alaska up here, prevalence of greater than 30% for obesity. I want to notice here in Northern Africa, getting into the Middle East, also very high rates. Here in Papua New Guinea, for example, we're also looking at very, very high rates of obesity. But I want you to notice that there's not one area that is untouched. There is lesser obesity if we get into sub-Saharan Africa, for example, but not anyone is really out of consideration for this disease process. Now, as someone who cares for both pediatric and adult patients that have obesity, I do want to get into both girls and boys as pulling the newest available data for girls living with either overweight and obesity. I think we can see a similar pattern for what we saw with looking at adults. Here, looking at our slides, looking here at us in the United States, going to South America also, parts of Northern Africa, when we look at those really higher rates of obesity. And then when we get into boys living with either overweight or obesity, we see similar things. Now, what you'll notice here is that intensity for boys, we don't see as prevalent here in the United States. We do see it as we get into Mexico and into South America. We do see some areas of intensity here in Europe, also in the Middle East, for example. Now, when we talk about obesity, it's important to recognize that there are over 230 comorbidities associated with this disease. And I'm just going to point out a few that you can see here on your slide. We're looking at migraine headaches, pseudotumor cerebri, which is otherwise called idiopathic intracranial hypertension. We have dyslipidemia or high cholesterol, non-alcoholic fatty liver disease, indeed becoming the #1 reason for liver transplants in the country, no longer alcoholic liver disease, but moving into fatty liver disease. Metabolic syndrome, a precursor to type 2 diabetes, degenerative joint disease, venous stasis disease, gout. And you can see depression, obstructive sleep apnea, asthma, cardiovascular disease, hypertension, GERD, urinary incontinence, polycystic ovarian syndrome. And these are just a few of the issues related to obesity that are called out here. You can recognize this affecting every organ system of the body. And what we often do is we treat the downstream impacts. So we'll treat the migraine headaches, or we'll treat the asthma, we'll treat the reflux disease, but never treat often the underlying cause, which is the obesity itself. Just yesterday, when I had one of the Harvard medical students rotating with me, she remarked at how people were being treated and how we were deleting diagnoses from the chart. She said, wow, so their obstructive sleep apnea is no longer there. They no longer have high cholesterol. Their type 2 diabetes is also in remission. And it goes to show you that we have been approaching this disease wrong for quite some time. So let's look at the historical landscape of obesity treatments and the reluctance of using obesity pharmacotherapy, or what we call anti-obesity pharmacotherapy. And I'm going to take you through a timeline of the Federal Drug Administration here in the United States and anti-obesity medication approval. We're going to take it back to the 1930s. So what you can see here is DNP was approved back in 1933 and then withdrawn just a few years later, and 5 years later, as you can see. Methamphetamine, which we know is not quite what we would typically use for obesity, in 47, and then really phenmetrazine. We start seeing this really combination, particularly phentermine, being approved back in 1959, moving in a lot of the amines, right? Bensphetamine, phenylpropylanamine, I can't know if I can say that correctly, along with rainbow pills. You can see these are withdrawn really, really quickly, along with methamphetamine being withdrawn. And then really a key drug is approved in 1973, fenfluramine. But this has created a lot of the stress and strain surrounding use of medications because fenfluramine was withdrawn. What I really want to notice particularly here is that one of the key issues with fenfluramine is that it caused heart valvulopathy. It was part of the fen-phen combination. Fen-phen was a combination of fenfluramine and phentermine. People are still scared to use phentermine because it played with a bad kid on the playground. That was fenfluramine. However, we have never seen issues with that. I want you to see that then sibutramine was approved in 97, then orlistat approved, still on the market, available in your local drugstores and by prescription at a higher strength. And then we move over into 2010, where sibutramine, which was approved in 97, was then withdrawn from the market. 2012 was a major time where we start to see many anti-obesity medications approved. We start to see lorcaserin, phentermine topiramate in combination approved. Then we saw liraglutide, the first GLP-1 agonist approved for obesity, and naltrexone and bupropion. Of note, lorcaserin was withdrawn at the beginning of 2020, right before the COVID-19 pandemic. And you can see that one of the key issues was increased cancer risk, particularly in those that were being treated. They saw 7.7% of people being diagnosed with cancer versus 7% in the placebo group. Finally, in 2021, semaglutide was subsequently approved. So you can see a lot's happened, a lot of withdrawals that can lead to some hesitancy. I do want to talk about the current agents that are currently approved here in the United States for the treatment of obesity. They include phentermine. Remember, that was approved way back in 1959, the first one on this list to still be here. Phentermine and topiramate, anytime you see a star, that means it's approved for the chronic treatment of the disease of obesity. We have diethylpropion, phendimetrazine, and bensphetamine. And then we have antidepressants, dopamine reuptake inhibitors, and opioid antagonists. This combination medicine of bupropion and naltrexone approved for chronic treatment of obesity, as noted by the star. We have several GI agents, including orlistat, which you remember was approved back in the 90s, followed by GLP-1 agonists, liraglutide, a once daily injection, and then semaglutide, the second generation, and once weekly injection for the treatment of obesity. So let's look at why, we've been talking about anti-obesity medicine and the addition of this to lifestyle to address chronic disease management. And I really want to look at this particular slide because it gives us a lot of information about the percent of weight loss that's conferred from lifestyle, surgery, and or anti-obesity medications. What you'll see here in this column is percentage of total body weight loss, either 5, 10, 15, 20, or 30%. And I want to look first at lifestyle modifications. So these are patients in behavior programs like WW or IBT, which stands for intensive behavioral therapy, usually 14 to 16 weeks of continuous check-ins with dietitians, physicians, and other advanced practice providers as it relates to behaviors surrounding overweight and obesity, particularly with a focus on diet quality, and physical activity. What you'll see here is that in terms of those who will lose about 5% of their weight, 48%, 10%, 25%. As we get into these higher percentages of total body weight loss, particularly as we get out here to 30%, only about 4% able to achieve this with lifestyle alone. Now we can contrast that to surgery, and this is looking at patients with surgery at 10 years post-op. So about 97% would still have lost 5%, and over 40% would have achieved greater than 30% total body weight loss. With regards to medications, I do want to show you what we see from the studies, which are all noted here at the bottom of the slide. Patients on liraglutide plus intensive behavioral therapy, what we can see here is that there is some increase in added benefit for lifestyle interventions with the use of medications plus intensive behavioral therapy. We see that with liraglutide, where we can see, a third increase across the board. Not as much with semaglutide, which is a more potent GLP-1 agonist. What you can see here is, though, that we do get some benefit with the intensive lifestyle therapy. Skipping over phentermine and topiramate because we don't have that study, but we can look at bupropion and naltrexone. And again, what we can see is an increase in response with intensive behavioral therapy. So what has changed recently and why? And I think a lot of the conversation has been around the GLP-1 receptor agonists. So I do want to start off looking at the one that is currently approved by the FDA for the long-term treatment of obesity, and that is semaglutide, a once-weekly injection. This is taken from the New England Journal of Medicine, that study that was published by Wilding and colleagues back in 2021. And I want to show you that on this axis, we're looking at percentage of total body weight loss and weeks since randomization. So going out to 68 weeks, what you can see is that when we compare placebo to semaglutide in the treatment group, we do see a significant difference. Indeed, these people that are on semaglutide out to 68 weeks, achieving on average 15.5% total body weight loss. What I do also want to show you here is semaglutide compared to placebo, showing those that lose 5, 10, 15, or 20% total body weight loss. And I do think that we can see some major differences compared to placebo. So here in the placebo group, about a third achieving 5% body weight loss, where we're looking at 86% here, with greater than 10%, about 12% under the placebo group, and 69% that are in the semaglutide group. Here, 4.9% achieving greater than 15% of placebo, but more than half achieving it in the treatment group, and then a third achieving greater than 20% total body weight loss. Now, I do want to mention another agent that has come on the scene, not necessarily yet for the treatment of obesity, but has been approved for the treatment of diabetes in 2022. This is showing you the trials, and this is taken from the Lancet and the New England Journal of Medicine. First, we'll look at the SURPASS trial in diabetes versus diet and exercise with this dual agonist. This is a GLP-1, a glucagon-like peptide 1 agonist, in combination with the GIP, or a glucose insulinotropic polypeptide. What you can see here is that if we're looking at diabetes versus diet and exercise and weight change, what we do see are some differences as we go out when we're looking at treatment. So those that are on treatment achieving a much higher degree of weight loss compared to those without treatment. And you can see that here. What I also want to notice is when they looked at the SURPASS trial comparing those that were on tirzepatide versus semaglutide at 1 milligram, we do see greater hemoglobin A1C reduction, which means average blood sugar, and greater percentage of weight reduction. And then the important SURMOUNT trial that also came out last year with Anya Yastroboff and colleagues out of Yale. What we can see here is tirzepatide, which is the treatment group, achieving at 15 milligrams about 22.5% total body weight loss in the trial versus the placebo group achieving about 2.4% total body weight loss at greater than 72 weeks duration. Now, when we look at the medications, how they're taken and what their weight loss efficacy is, we've gone over a little bit of this. Orlistat, you can see here, is taken 3 times daily. When we're looking at outcomes, at 1 year and 2 year, we're looking between 2 and 3% or 4% weight loss. Phentermine and topiramate, which was touted as kind of the best prior to the introduction of the long-acting GLP-1 agonists, we can see that 5% weight loss is achieved in about 2/3 of patients, and close to half will achieve greater than 10%. With bupropion and naltrexone, we see 42%, and then 21% with greater than 10%. Liraglutide, this is that once daily sub-Q injection, usually given in the abdominal region. You can see about 2/3 achieving 5% weight loss, a little bit less than phentermine topiramate, and less also than phentermine topiramate when we're looking at the 10% weight loss. And then that once weekly semaglutide, where we see much, much higher percentages, as we previously noted, 86.4% achieving 5% total body weight loss, 69.1% achieving greater than 10%, and then more than half achieving greater than 50%. Now, when we look at adverse effects and contraindications to use of these medications, I do want to note that across all agents, pregnancy is a contraindication. So you will see that across all of the medications, we do not recommend these medications, and they have not been tested in patients who are pregnant. And I would even extrapolate that to those who are breastfeeding. In addition, what you'll see with orlistat, being that it's a pancreatic lipase inhibitor, adverse effects and can include diarrhea and oily stools, fecal incontinence, and issues with fat-soluble vitamins. That's vitamins A, D, E, and K in terms of their absorption. Phentermine topiramate, what we'll see, particularly from the stimulant portion, is things more like dry mouth, constipation, and nausea. We can get some headache, dizziness, and fatigue more from the topiramate portion of it. Hypoglycemia, back pain, and cough. You can see it's contraindicated in patients with a history of glaucoma, both closed and open angle glaucoma, hyperthyroidism, and uncontrolled hypertension. Naltrexone and bupropion. Bupropion, of course, first receiving its approval as an antidepressant. Naltrexone, what we call an opioid receptor antagonist. Adverse effects are similar to what we see, particularly in this first 2 lines for phentermine topiramate. Headache, dizziness, and insomnia, more due to the stimulating effects due to the bupropion, nausea and dry mouth, and constipation and or diarrhea. Pregnancy, of course, again, a contraindication. We do not use this in patients with uncontrolled hypertension, much like we saw in the phentermine, and we do not use this with patients with a history of seizure disorder secondary to the bupropion component. Obviously, we would not use this when patients need opioids because this is an opioid antagonist. It's what we use for patients without opioid use. And we don't use this in patients with a history of eating disorders or MAOI use in terms of medications. For our GLP-1 agonists, we see nausea and vomiting. This is definitely, and nausea is the number one side effect, up to 44% initially when starting, but a mitigating or decreasing with titration of dose. Diarrhea and constipation, headache, dizziness, and fatigue, hypoglycemia, and abdominal pain, really contraindicated in a personal or family history of medullary thyroid cancer, multiple endocrine neoplasia type 2, and you do want to have significant caution in patients with a history of pancreatitis. Now, one of the reasons why I think the GLP-1s have really emerged as really key players is because of what you see here. These are the trials that have been conducted looking at the cardiovascular and non-cardiovascular outcomes. The trials are the Elixir, Leader, Sustain, Excel, Harmony Outcomes, Rewind, Pioneer, and the Amplitude O studies. And what you can see here is that there are a lot of positive parameters. I want to note that p-values of less than 0.05 are considered significant. So when we look at 3-point MACE, or major adverse coronary event, it's significantly impacting patients to not have major adverse coronary events. It significantly reduces cardiovascular death, significantly reduces fatal or non-fatal myocardial infarctions, which are heart attacks, fatal or non-fatal strokes. It significantly reduces all-cause mortality. That means death from any cause. It significantly reduces hospital admission for heart failure and significantly reduces composite kidney outcomes, including macroalbuminuria, which means heavy protein within the urine. The only thing it has not been shown to significantly reduce is worsening of kidney function, which we'll notice does not have a p-value of less than 0.05. I do want to thank you for your time. Again, I'm Dr. Fatima C, Stanford. I'm going to turn it over to Dr. Hu, who will now take over for the next portion of the presentation.
Thank you so much, Dr. Stanford. Sorry, I have a severe attack of seasonal allergy today, so I might sound a little bit nasal. Let me start my video and share my screen. Excuse me. Okay, perfect. So I'm going to switch gear a little bit for the next 10 minutes or so. I want to give you a little bit review on how dramatic or drastic weight loss, particularly recently weight loss with assisted medication, can affect patients' physical appearance as well as their psychomental status. I'm coming from with the perspective of being a full-time clinical dermatologist. I'm on staff at University of Miami Miller School of Medicine. I have no conflict of interest. And feel free to save your questions for later. We'll have an interactive Q&A section after this 10-minute talk. So in addition to weight loss, improvement in cardiovascular parameters, I'm sure a lot of your patients or colleagues have talked about the physical appearance aspect of these weight loss medications. So the term Ozempic face was initially coined on TikTok, which is, like a viral social media platform for the young millennial Gen Z generation. But interestingly, in the recent weeks, even major news media such as New York Times, as well as Forbes, have been covering this new trend, quote unquote, as Ozempic face, and how that relates to weight loss and our society obsession with beauty and physical fitness, etc. So Ozempic face refers to a dramatic change in a person's physical appearance, especially facial appearance, as a telltale sign of being on a dramatic or drastic weight loss journey. And then typically people have a high cheekbone, kind of sunken cheeks. They look a little bit gaunt. So in the layman social media world, unfortunately, it kind of goes back to the 1980s, the heroin chic, where models were walking around with very low BMI and they look anorexic. And so this Ozempic face is almost like a resurfacing of a fashion pendulum going back towards this underweight look, very unrelated to using these medications to achieve control of diabetes or other important health parameters. So I'm going to give you a little bit more of a dermatology perspective on how weight loss affects physical appearance as well as mental health. So interestingly, Ozempic face is not anything new. Even though we don't really have any published literature on this phenomenon, but we can refer back to the 1970s, 80s, even as recent 2000s, when we had HIV/AIDS lipodystrophy, particular lipoatrophy of the face, as well as massive weight loss from bariatric surgery in the 2000s and even recent years. So let me start with HIV/AIDS lipoatrophy. I'm not sure how many of you in the audience have seen this in practice or have treated patients with this condition. So when HIV/AIDS was more of a epidemic or pandemic back in the 1980s, one of the telltale sign or physical stigmata of the disease, as well as patients on heart medication, is that they have significant facial wasting or lipoatrophy associated with lipodystrophy of the body. So they look aged, thin, gaunt on the face, as you can see on the screen. On the left-hand side panel are the pre-treatment facial stages of HIV/AIDS lipodystrophy. So they start with mid-face hollowing. So this really refers to hollowing of the mid-face fat pad. And then eventually they lost the medial facial fat pad. And then in stage 3, they also have significant hollowing of the temple. And then stage 4, which is the most advanced HIV/AIDS lipoatrophy of the face, what you really see is just really skin overlying musculature of the face. So very skeletalized look. So to remove this physical stigmata of the disease, as well as heart medication, FDA approved the application of Sculptra, or the generic name is poly-L-lactic acid, to treat this condition. So that was really one of the key revolution or innovation in dermatology and plastic surgery to provide treatment option for these patients who do not want to have this physical stigmata of the disease, want to have better quality of life. As you can see on the right side panel, these are patients who have received 3 to 5 sessions of the poly-L-lactic acid treatment specifically to address a lipoatrophy of the face. As you can see, there's significant improvement in mid-face volume, softening of the nasolabial fold, and improvement of the temple. And a lot of times that actually can be life-changing for a lot of these patients. And we do see still men with a similar HIV/AIDS lipodystrophy in our clinic, and then we do the same treatment, even though this is not anything new. But definitely this phenomenon of lipoatrophy or lipodystrophy from a disease definitely kind of gives you a little background information on how volume loss of the face can age a person's physical appearance. Now, in the 2000s, when bariatric surgery became very popular, more people obese patients are seeking the surgical intervention. And interestingly, one of the side effects of rapid weight loss assisted by bariatric surgery is facial aging. So in this publication, so they were really focusing on how facelifts can address concerns of facial aging after massive weight loss from bariatric surgery. So it presented 2 patients pre-facelifts, but they both have had significant weight loss. So in this first panel, you have a 57-year-old man with 140-pound weight loss in a short amount of time after bariatric surgery. As you can see, his face actually looked very similar to what I showed you earlier in these patients with lipoatrophy from HIV/AIDS. So significant hollowing of the mid-lateral cheek, in deepening of the nasolabial fold. And then in this woman, 64-year-old woman with over 100-pound weight loss, you see similar finding. But on the side view, you see even more of this kind of accumulation of loose skin or inelastic skin folding of the face. So all these are signs of advanced aging, gives people a perception of advanced aging, even though their chronological age hasn't changed much. As you can see, this, even though it has very little health impact, quote unquote, but definitely affects a person's psychosocial well-being. And the underlying pathophysiology. So in the case of semaglutide and similar medication, I really don't think it's the medication itself leading to facial volume loss. It's really rather related to weight loss overall. But the underlying pathophysiology in these scenarios of rapid decrease in body mass is that you have fat loss. So when you have loss of certain key facial fat pads, such as the medial facial fat pad, the buccal fat pad, you actually give a patient a more advanced appearance, and then that also changed the soft tissue envelope of our skin. So our skin becomes saggy, and then you have this collection of skin fold or excessive inelastic skin. And for sure, this does have significant physical and psychosocial comorbidity. Interestingly, as our face shows these signs of rapid weight loss, our body experiences similar changes. So patients may have extra skin folds, and this is the patient that we recently treated at our South Beach Symposium, which is a dermatology conference, where this patient actually had gone through a recent rapid weight loss on semaglutide and noticed a much dramatic worsening of her cellulite in the posterior thigh area. So you have cellulite, you have more saggy skin, you may have skin folds. And the psychosocial impact has been documented very well throughout the literature. There's many studies documenting the impact of rapid weight loss. For example, one study found that about 40% patients with massive weight loss, so in which they either have lost over 50% of excessive body weight above their ideal weight, or have experienced over 100-pound of weight loss in a short amount of time. So that's the definition of massive weight loss. So 50% of these patients at time of seeking plastic surgery have a diagnosed psychiatric disorder such as major depression or anxiety. And then in another study, they actually followed 70 patients undergoing bariatric surgery. So this study found that at baseline prior to surgery, the mean facial age perception was about 41 years of age. But after surgery, the mean facial age perception was at least 3.7 years older with a significant p-value, even though the chronological age has not changed that much. And they also found that older patients are more susceptible to changes in facial volume caused by weight loss. So meaning that younger patients may have a little bit more resilience in collagen production, so may be able to compensate faster when they have significant weight loss compared to older patients. And this is this is also what we see in the real world. So when we had patients coming in, they're really happy about what they see in terms of weight loss, changes in their diabetic parameters, or cardiovascular, improving their cardiovascular health. But at the same time, when they're bothered by how gone they look tired, they want to have a fresher look. So this is where we need to have a comprehensive approach to address their concerns. First, we need to discuss weight stabilization. I usually don't start treatment until they're almost close to their body weight, but sometimes we do start treatment depending on how fast they're losing weight. And of course, we want to optimize nutritional and mental health support. And then in terms of specific strategies to address facial and body changes from rapid weight loss, that definitely requires another lecture on its own, but I'm just going to go over some of the key principles. Basically, we have two major approaches. One is to use various injectables to correct facial volume loss and address sagging of the skin. And the second major approach to use is to incorporate energy-based devices to tighten and resurface the skin. So I'm just going to briefly go over a couple of case studies. So these are not patients with rapid weight loss, but they're patients with weight loss either intentionally or from illness or from lifestyle. So they're not specific to semaglutide patients with the Ozempic phase, but it kind of gives you a similar idea about how we generally approach patients with facial wasting or lipoatrophy or loss of facial fat. So in this patient on the left-hand side, she's just a very thin patient, very thin throughout her life. And as you can see, she has significant volume loss, particularly lower face. So we were able to kind of bring back a couple years back to her face, but still kept her natural appearance by using hyaluronic acid fillers. And hyaluronic acid fillers have shown efficacy and safety in restoring facial volume loss, because it really serves as an implantable gel that will slowly dissolve or digest by your own body's fibroblasts and dermal circulation. So it's not permanent, but it gives patients a result that can last up to anywhere from 12 to 24 months. Of course, maintenance is key. And then on the right-hand side panel, so this is the patient who had intentional weight loss. And even though she felt really good about herself, very proud of her weight loss when she started seeing me, but she was bothered by that very gaunt, thinned out look on her face, because she felt like, oh, well, I just looked older than I feel. I want to look younger. Again, the problem is a loss of mid-facial fat pad as well as buccal fat pad. So here we treated her with 3 sessions of polylactic acid, or Sculptra, gave her pan-facial rejuvenation. You can see just a soft improvement in global volume of her face, and that definitely turned back the clock by at least a few years. Again, the goal is to bring patients back and discuss options. And a lot of times we will have polylactic acid, dermal filler, and sometimes we even use calcium hydroxyapatite, which is a center panel. Is labeled under the label of Radius as another biostimulator. And then when patients have more of that concern of cellulite, crepey skin on the body, this is where we can also bring in energy-based devices such as radiofrequency with microneedling. So this is a patient who had a lot of weight loss after twin pregnancy. She had a lot of stretch marks and crepey skin. So this is right after treatment. And then lastly, so this is a patient I just showed you earlier. She has significant cellulite notice after being on semaglutide for weight loss. So we were able to treat her during our South Beach symposium in our live session. So this is right before and after injection treatment with calcium hydroxyapatite. I think I saw 2 raised hands. I can finish I think I have just one more slide left over, and then I can address the questions. So the key points is that when you see patients coming with concerns about facial aging, body concerns after rapid weight loss, it's important to talk about weight stabilization. It's important to give them psychosocial support, discuss their nutrition. And when we, as dermatologists, we like to make plans that often require multiple sessions for the most optimal correction of facial volume loss, or give them tightening effect of various body sites. And then, of course, extreme cases, I definitely will benefit from either facelift or penniculectomy. So this concludes my section. I'm not sure how to get to the raised hands.
Dr. Hu, we'll actually handle that on our end. So thank you again to you and Dr. Stanford for that lovely presentation. Let's go ahead and take a couple of questions that we have from the audience. And our first question asks, dysbiosis and obesity, could you please comment on that?
I'm going to stop sharing my screen.
What was your question, Amanda?
Sure. The question was dysbiosis and obesity. Could you please comment on that?
Is there any more specifics?
There isn't, unfortunately.
Okay, so I think we should move on because it's not a really specific question. Can we go into something that's a little bit more specific?
Of course. So this one is a little more involved. It asks, any idea if or when tirzepatide will be approved for weight management? Thank you.
Yeah, absolutely. So tirzepatide, is there a second part? I mean, I'll listen to you so I can.
There's a bit more, yes. It says, to your point, GLP-1RA has been a game changer in the field of weight management and T2D. The data extends up to 68 months. Recognizing this as a chronic disease, should we be suggesting these medications continue for a lifetime? Additionally, can you discuss the access issues for GLP-1RAs? Yes, they are effective, but they are getting to the person. Are they getting to the persons that need them?
Absolutely. So let me see if I can remember all of the questions. Tirzepatide, which is the dual GLP-1 GIP agonist, has been fast-tracked for approval through the FDA. As you guys know, it did receive approval in 2022 under the trade name of Mounjaro, and only used now in patients with type 2 diabetes, which is one of the issues that was noted in the second part of the question. So we do anticipate that the FDA will likely approve it. I would say prior to the end of the summer, if the fast track stays on schedule. I mean, it's the government, so we'll see what happens. Number two, when we're looking at GLP-1 agonist, yes, we've seen some great benefit. Yes, we've seen some access issues. And so this is definitely a major issue. What I can find here in Massachusetts, in the Commonwealth of Massachusetts, is that thankfully our private insurers do cover anti-obesity medications. But we do know that under Medicare, for example, that anti-obesity medications are a complete exclusion. We've been trying to fight this. We, meaning the obesity community, have been trying to fight this in Congress starting in 2013 with the Treat and Reduce Obesity Act, which seeks to cover anti-obesity pharmacotherapy in addition to allowing individuals that are complementary to the care that we provide as physicians to care for patients with obesity, i.e. our dietitian colleagues, our physical therapy colleagues, our exercise physiology colleagues that do their jobs quite well and are quite complementary to the work that we do in obesity medicine. Currently under Medicare, for example, if you want to meet with a dietitian and you are under the Medicare population, you do not receive coverage of that visit if you only have obesity. You have to get type 2 diabetes to then meet with the dietitian and have that visit covered. So we wait for you to get diabetes for you to meet with the dietitian, which seems a bit backwards to me and to those of us that are advocating for a different strategy. In addition to the Medicare population, under many circumstances, those that are our low socioeconomic colleagues are often without GLP-1 agonists, particularly as it relates to the treatment of obesity. We do find that under Medicaid in most states, we are able to get GLP-1 agonists, which extend beyond what I covered here. Dulaglutide, for example, Trulicity, which is approved for type 2 diabetes, exenatide, which was the first GLP-1 agonist approved back in the early 2000s. All of those we can typically get for patients with diabetes, but we do not have the ability in many circumstances to get these in patients with type 2, without type 2 diabetes, but with obesity. I can tell you that that is still in place here in Massachusetts, where there is indeed law on the books here in the Massachusetts State House that excludes anti-obesity medications for coverage for our Medicaid population, which is indeed unfair, secondary to the higher burden of disease in lower socioeconomic populations. I think there was another part to that question. I don't know if I got to all of the parts of the question, Amanda. Was there something I may have missed, some little nuance?
I believe you covered all the segments of that question. Thank you so much.
All right. Thank you.
We do have another question. What happens when you stop using these drugs?
Absolutely. So I think that was the third part. Actually, now I remember it now that you said it. So I didn't go over the pathophysiology of the disease because I didn't have the time allotted. But what I will talk about, particularly for any of the medications, whether it's the GLP-1 agonist or any of the other medications, is that they only are effective if utilized. So we wouldn't expect an antihypertensive to work if we're no longer taking the antihypertensive, i.e., medicine to treat high blood pressure, or if we're using a medication for diabetes, that's no longer going to be effective if it's out of our system. So if we take these medications away, unfortunately, the patient will have weight regain, typically back to where they were prior to starting the intervention. So these are approved for chronic use. You'll notice that I said the use starting in 2012, particularly with an exception of Orlistat, which was approved for chronic use well before. All of the medications that are approved 2012 and beyond were or have been approved for the chronic disease of obesity. And another way that I really kind of think about this, particularly as we think about lifestyle and the importance of lifestyle interventions, is no one expects, your workout that you did back in 1998 to still last you today. You have to consistently work out. In terms of diet quality, nobody expects that really great, foods, pattern that you had back in 2005 to still work now. It's something that you have to continue. And similarly, with these medications, if they're not being utilized, if effective, and notice I put a lot of ifs there, not everyone is responders to any of the medicines I talked about. And for many patients, there is a lot of trial and error to find out what's effective for them. So finding the best treatment strategy for them is what's most important. But these do require long-term chronic use if that patient is a responder to the medications. And another study that was published in the Lancet after the study results that I showed you that showed that when we withdraw the medicine, you do start to see that rapid weight regain, which is to be anticipated because you're no longer doing what was effective for that person. So thanks for that question.
Thank you. And this question is actually for both of you. In your current practices, are you seeing increased interest about being on these drugs, perhaps from patients that do not have an underlying medical condition or medical risk? And how do you deal with that?
So I'm going to go first so Dr. Hu can lead off. I'm an obesity medicine physician, so there's no way for you to get into me unless you have obesity and obesity-related disease. So I can't say that I'm getting people that are inappropriate because you can't make it through to see me if you're inappropriate. You're screened out before you could even get to me. And unfortunately, our wait to be seen at our MGH Weight Center, we have a list of over 5,000 patients waiting to be seen. So it is unfortunately quite a large list, only continuing to dramatically rise as people start to recognize obesity as the chronic disease that it is. And so I don't have that. I would say that probably some of my primary care colleagues might run into that situation since they're treating people that don't all have, the disease of obesity or obesity with obesity-related diseases. So I'm not quite that person as a specialist that only cares for patients with obesity. So that I can't really speak to that, but I'm certain that my primary care colleagues and those that are, endocrinologists, cardiologists, gastroenterologists, those that are also caring for this patient population might be getting some requests that align with this. But I would say that when we look at the sheer volume of obesity in this country and the adult population, over 110 million adults with the disease, what I can tell you is that based upon my paper that I published in 2021, only 1% of patients that met criteria for anti-obesity medications were on them by the end of 2021. So that's very small percentage of the population. I would say with the recent buzz, we probably have seen an increase to about 2 or even 2.5% of the population that meets criteria. So I think we can say that it's still, a significantly lower than any other disease process in terms of treatment with anti-obesity medications. But I'm going to turn it over to Dr. Hu to see what she sees.
Oh, thank you, Dr. Stanford. Obviously, I am a dermatologist, but I work with a lot of patients who are actually completely opposite probably for what Dr. Stanford sees in her clinic, in the sense that they're more focused on like the physical appearance. So I have patients who have perfectly normal BMI, who probably will be goals for a lot of patients with obesity to aim towards but ask me about this semaglutide or Ozempic or Mounjaro, just because they've seen some celebrities in Hollywood taking it, looking great on the red carpet 3 weeks later. So yes, this may not be the norm elsewhere in the country because I practice in Miami, but I do think in certain major metropolitan areas where there's a little bit more of a obsession with beauty and trends, we're seeing this unhealthy I would say interest in medication that really meant for people who have diabetes or obesity. And then just as a side note, this is a completely anecdotal. One of my patients, he runs a clinic. He started a semaglutide clinic. He charges people X amount of dollars to get in. They pay a X amount of dollar for a subscription for quote unquote generic semaglutide. He's expanding his practice to 3 other locations elsewhere in Florida, outside Miami. That speaks to the popularity of certain services like this. And so me being a very academic practitioner, I don't condone this. This is not the appropriate use of these medication. You can see side effects, especially in healthy people who are not being monitored. So I think as practitioners, we have an ethical duty to educate the public on appropriate use of medications. Very important. This is definitely as important as speaking on the benefits and risks.
And I just want to give an amen to what Dr. Hu said. I am from the South, so we're going to throw that in for a second, because I think that she speaks volumes to what we see. I have a patient population that needs treatment. These are patients that are struggling with very severe disease. These are not the patients that it sounds like are being seen at concierge practices and things of that sort. And these are the patients that are willing to wait for however long it takes to get the care that they need. I really do caution against inappropriate use, much like Dr. Hu said, for medications, for vanity purposes. The goal is not vanity. For me, none of my slides talked about the vanity benefit. This is not what I'm going for. I'm going for prolonging life. I'm going for promoting quality of life. It's important to note that with my patients, actually, I never comment on how they look unless they have a cute scarf or cute glasses or something on. Don't comment on their physical appearance, because let's say I do comment on their physical appearance after they've achieved great weight loss and say, wow, you look great. That implies that they didn't look great before. And that sets up disordered thinking and disordered behavior. So I will comment on their labs like, wow, look at how stunning this glucose is. Or, oh gosh, this is a very, very phenomenal looking lipid panel, which is cholesterol values. It really starts to divert the attention to the health benefit that's being gained, not how someone looks. I could care less about how you look for your wedding or for your class reunion or whatever else. I guess I'm not on South Beach in Boston, where most people are covered most of the time. And so that's not the focus. But I caution for those people that are listening that are doing things that are inappropriate that can ultimately lead to negative outcomes, to let's use have the people that need these use these appropriately. And this is not about a get rich quick scheme for people that are choosing to do this inappropriately. Let's treat the people that actually need treatment. And there are a lot of those people that aren't getting the care they deserve and they need.
Thank you both again. And another question for both of you: what is the role of clinicians in educating patients about how these drugs work, the efficacy, safety, and the need for long-term use?
So for me, since I, obviously utilize these medications quite frequently, and it's across the spectrum, the GLP-1s didn't hit the scene, the once daily until 2015, and then the once weekly until 2021. So those are very, very new. But as someone who's been practicing in the field for close to 20 years, we were using, several agents prior to that. Whenever I'm starting a patient on a medicine, I will go over, first of all, how the brain is regulating weight. And then I'll actually show them where in the brain or in the body the medication's working, so that they understand. And that's regardless of their education level, whether their education level is at 8th grade or whether they have 5 degrees like me. My goal is to help them understand the why behind, this. This is not, because something's wrong with you. It's just, we have to fix this part of how your body's signaling. And I think that really helps people understand the why. And also it helps them understand that if it's not effective for them, or if it's not working for them, that it's not their fault. Again, it's just how their body works. Not everyone responds to the same high blood pressure medicine. Not everyone responds to the same diabetes medicine. It's a lot of trial and error to figure out what works. And I explained to them that, look, if this works, we will be using this long term. This is not a failure on your part. It's just, if it works, if we pull that back, you'll have that weight regain. Dr. Hu, any thoughts? You're mute, I think, my dear.
I don't prescribe these medications, but I can definitely share experience with my patients. For sure, I do think the rebound is real. I have patients who have gained weight back as soon as they stopped. Again, they were using it more for achieving a certain body ideal rather than for obesity. And I also had patients who have gotten very sick and say it's the evil medication, it's the worst medication, don't ever do it. Again, these are scenarios where you're not administering the medication under appropriate indication, and the patient will not educated properly. So these are the risks you run into. And then as a dermatologist treating a lot of concerns of facial aging, I do have to say that the facial aging with rapid weight loss is real. Again, having a slow, steady weight loss achieved with appropriate medication and lifestyle is really the best way to achieve weight loss, to avoid these rapid facial aging that patients may experience. Again, even though they're trivial, but for certain patients, that definitely has a significant mental impact.
Thank you again. And for our next question, If a patient sees a cosmetic dermatologist to correct the facial gauntness caused by Ozempic, what happens if they stop taking this medication and gain the weight back in the face? Is this something to be concerned about? Also, are there certain cosmetic procedures that you would use that might keep this possibility of weight gain back in mind?
So that's a great question. So our face, as we age, it's going to lose its resilience. So the concern of over treating the patient for weight loss associated with facial aging, and then what happens when they regain the weight back is more of a concern in younger people, because they definitely have a little bit overfilled look if you're treating to a ideal facial image and then they gain weight back. But interestingly, for older patients, it's very difficult to overtreat when they have experienced rapid weight loss and significant facial aging. So when they gain their weight back, even when they're gaining weight back, they may never get back that youthful appearance. So in older patients, that's less of a concern. And this is where a discussion with the patient is very important. I talked about, okay, so you're at this weight. What if you gain weight back? And this is something we can anticipate. So less of a concern in older patients. And then in terms of, there was a second component of the question about, can you repeat that, Amanda?
Sure. The second question asks, are there any certain cosmetic procedures that you would use that might keep this possibility of weight gain back in mind?
Right. So this is where I definitely have a preference for biostimulators like polylactic acid and calcium hydroxyapatite, because the results from these biostimulators are much more subtle. They're more quote unquote natural in the sense is that the results you get from these treatments are from collagen production, type 4 collagen production from your own fibroblasts in response to the treatment, rather than a implanted gel in the case of injecting hyaluronic acid fillers. So they're going to give you more of a lifting effect rather than just volumization. So even when patients gain weight back, they can accumulate a little bit of natural cheek fat pad around the area you had biostimulation, but they will never really look too unnatural. So again, biostimulators will be my first go-to, followed by tightening devices, and followed by dermal fillers in certain facial areas.
Thank you, Dr. Hu. And our next question, this is specifically for Dr. Stanford. What is the longest time that you have had your patient with GLP-1 antagonists?
How long?
Or agonists, I'm sorry.
Yeah. So the longest that I've had patients on it would be the people that were Saxenda early treaters. So that would be 2015. A lot of the patients that were on Saxenda did convert over to the longer acting GLP-1, which is semaglutide or Wegovy. There are some that still wanted to remain on Saxenda just because they were high responders. So I would say that the total number of years, the length of time that I've had anyone on a GLP-1 agonist is 8 years in duration. For medications like phentermine and topiramate, I've had certain patients on these in excess of 20 plus years. So that's what I see in my practice.
Thank you. Our next question. Can a strong commitment to exercise and healthy diet maintain the effects if a person or a patient decides to stop the medication?
So no, I think it will help maintain where they were prior to the use of the medication. So let's say they were at a certain level. It unfortunately won't prevent the weight regain because the diet and exercise isn't really acting on those pathways of the brain that are being modified by the medication. So GLP-1s work to upregulate the pathway of the brain called the POM C or the pro-opioid pathway, which tells you to eat less and store less. And it downregulates the AGRP or the Goody-related peptide pathway, which tells you to eat more and store more. And so when you pull that back, that's the most potent component. It's no longer working on that. You will still see the weight regain. Maybe you can mitigate not getting completely back to baseline, but you will unfortunately regain a large majority of the weight with even diet and exercise. Most of the people are really invested in diet and exercise to begin with before going on these medications. And the addition of the medications is because the lifestyle by itself was ineffective.
And our last question, any idea when the supply will be better? Some patients hesitate to go on a treatment that they may not be able to continue. How can Groupon offer any assistance here?
So I don't work for any of the pharma companies, so I can only speak to what they've stated publicly. I can tell you that in my own practice, I've seen the Wegovy supply start to improve in January of 2023. I suffered, and when I say I suffered, i.e. me and my patients, for all of 2022. We weren't really allowed to have any new starts on the medications for about 6 to 7 months, secondary to the short supply. So I think that we're starting to see the tide turn. I do know our short supply issues are affecting approvals for these medications in other countries. For example, I just came back from Jerusalem and Tel Aviv, where I was speaking, and they were anticipating approval for semaglutide, which we've obviously had here for a few years. And their approval is being pushed back because of the short supply here in the US. So, I think that this is still going to be some challenge, and I do understand if there's hesitancy. We have not seen supply with liraglutide, which is the first generation GLP-1 agonist. And so I might recommend that if a GLP-1 is recommended, but then also recognize that these are not the only medications. We do have phentermine topiramate, bupropion, naltrexone, other drugs that have not seen the issues with short supply in the same way we've seen for the GLP-1s. So just a note there.
Excellent. Well, thank you again. And again, thank you to Drs. Hu and Dr. Stanford and to our audience for your attention. We hope that you got something useful out of this discussion. As a reminder, a full recording of this webinar will be available on both the LiVDerm and the CMHC website. We will also notify you by email when this becomes available. Please email info@cardiometabolichealth.org with any questions. And finally, throughout this year, we have several meetings spanning a diverse range of topics that will be upcoming. We invite you to join us in Orlando for the CMHC Spring Program, which is from May 19th through 20th. We will also have a masterclass focusing on women's health and wellness from August 17th through 20th in Southern California. And from October 6th through 7th, LiVDerm invites you to join the West Coaster meeting taking place in Rancho Palos Verdes, California. Finally, you can also join us in Boston for CMHC's 18th annual meeting, which will be from October 11th through 14th. Visit our websites for more details. Thank you again for joining us this morning and have a great day.